Hello everyone, and thank you for joining us today. This presentation will cover ultrasound-guided popliteal and saphenous nerve blocks. These two peripheral nerve blocks are frequently combined to provide surgical anesthesia and excellent postoperative pain control for procedures below the knee, especially foot and ankle surgeries. Throughout this presentation, we'll review the relevant anatomy, indications, equipment, ultrasound techniques, and important safety considerations needed to perform these blocks successfully. By the end of this presentation, you should be able to describe the anatomy relevant to both nerve blocks, recognize the appropriate indications and contraindications, identify the necessary equipment, understand the ultrasound-guided techniques for each block, and recognize potential complications, along with strategies to prevent and manage them. Regional anesthesia has become an essential component of modern perioperative care. Compared with opioid-based pain management alone, peripheral nerve blocks provide superior postoperative analgesia while significantly reducing opioid requirements. This often leads to fewer opioid-related side effects such as nausea and vomiting, earlier ambulation, shorter recovery times, and greater patient satisfaction. These benefits have made regional anesthesia a valuable tool for enhancing recovery after surgery. The saphenous nerve is the terminal sensory branch of the femoral nerve. It provides sensation to the medial aspect of the lower leg, extending distally toward the medial ankle and midfoot. Because it is purely sensory, blocking this nerve typically preserves quadriceps strength while providing excellent analgesia to the medial lower extremity. When combined with a popliteal sciatic nerve block, nearly complete sensory coverage of the foot and ankle can be achieved. The popliteal block targets the sciatic nerve before or at its division into the tibial and common peroneal nerves. These two branches initially travel together within a common connective tissue sheath known as Vloca's sheath. The tibial nerve provides motor and sensory innervation to the posterior compartment of the leg and much of the plantar foot, while the common peroneal nerve supplies the anterior and lateral compartments of the leg as well as the dorsum of the foot. Understanding this anatomy is essential for successful block placement. This diagram illustrates the sensory distribution of the major nerves supplying the lower leg and foot. Notice that the popliteal block anesthetizes most of the foot but does not reliably cover the medial aspect of the ankle and lower leg. That area is supplied by the saphenous nerve. This is why combining the popliteal and saphenous nerve blocks provides nearly complete anesthesia for many foot and ankle procedures. These blocks are commonly performed for foot and ankle procedures, including Achilles tendon repair, bunionectomy, tendon reconstruction, fracture fixation, and many other orthopedic surgeries below the knee. They may be used as the primary anesthetic with sedation or combined with general anesthesia to provide prolonged postoperative analgesia and reduce opioid requirements. Absolute contraindications include patient refusal, infection at the injection site, and allergy to the planned local anesthetic. Relative contraindications include coagulopathy, distorted anatomy, and pre-existing neurologic deficits. Each patient should be evaluated individually, balancing the benefits of regional anesthesia against any potential risks. There are many advantages to these peripheral nerve blocks. They provide excellent postoperative pain control, reduce opioid consumption, facilitate same-day discharge, and improve patient satisfaction. However, there are limitations as well. Performing these blocks requires ultrasound proficiency, adds procedural time, and may produce temporary motor weakness that can delay ambulation until the block resolves. Before beginning either procedure, ensure that all necessary equipment is available. This includes a high-frequency linear ultrasound probe, sterile probe cover and gel, an echogenic block needle, appropriately prepared local anesthetic, syringes, sterile supplies, and standard ASA monitors. IV access should always be established, and intralipid must be immediately available whenever performing peripheral nerve blocks in the event of local anesthetic systemic toxicity. Proper patient positioning greatly improves both image quality and needle visualization. For the popliteal block, the patient may be positioned prone or supine with the leg elevated and slightly flexed. For the adductor canal block, The patient is positioned supine with the operative leg slightly externally rotated. Comfortable positioning improves both procedural success and operator ergonomics. Here we see the key ultrasound anatomy for the popliteal block. First, identify the popliteal artery and vein. Superficial to these vessels is the tibial nerve, while the common perineal nerve is visualized laterally. Adjusting probe depth, gain, and using small heel-to-toe movements often improves image quality and allows better visualization of both nerves and the advancing needle. The procedure begins with a timeout confirming patient identity, procedure, allergies, and anticoagulation status. After applying monitors and positioning the patient, the ultrasound probe is placed transversely in the popliteal fossa. The tibial and common perineal nerves are identified and followed proximally until they join to form the sciatic nerve. The needle is advanced in plane under continuous ultrasound visualization while avoiding nearby vessels and direct nerve contact. After negative aspiration, a small test injection confirms proper needle placement. The remaining local anesthetic is then injected incrementally with frequent aspiration while observing circumferential spread around both nerve branches. For the adductor canal block, the femoral artery serves as the primary ultrasound landmark. The artery is identified beneath the sartorius muscle, with the vastus medialis and adductor muscles surrounding the canal. The saphenous nerve is often small and difficult to visualize directly, so successful block placement relies primarily on identifying the femoral artery and ensuring local anesthetic spreads appropriately around it. Following a standard timeout and patient positioning, the probe is placed transversely over the mid-thigh to identify the femoral artery within the adductor canal. The needle is advanced in plane toward the lateral aspect of the artery, while maintaining continuous visualization of the needle tip. After negative aspiration, a small test injection confirms appropriate placement. The remaining local anesthetic is then administered slowly in divided doses, while observing spread around the artery and adjacent saphenous nerve. Several local anesthetics may be used for these procedures. Bupivacaine provides prolonged postoperative analgesia, while ropivacaine offers a similar duration with somewhat less motor blockade. Typical volumes are approximately 20 to 30 milliliters for the popliteal block and 5 to 10 milliliters for the saphenous block. Always calculate the maximum safe dose based on the patient's weight and overall clinical condition. Although peripheral nerve blocks are generally safe, complications can occur. These include vascular puncture, hematoma formation, infection, nerve injury, block failure, and local anesthetic systemic toxicity. Careful patient selection, continuous ultrasound guidance, frequent aspiration, incremental injection, and vigilant monitoring significantly reduce these risks. There are several practical points that improve both safety and success. Always maintain visualization of the needle tip throughout the procedure. Aspirate every 3 to 5 milliliters during injection. Avoid injecting against high resistance. Document both the procedure and neurologic assessment, and continue monitoring the patient until discharge criteria have been met. These are the references used throughout this presentation, including educational materials from Apex Anesthesia and the NYSORA nerve blocks application. Thank you for your attention, and we'd be happy to answer any questions.